Thanks, Aileen. Here we go.
Not quite seeing it going on Facebook.
It's still setting up our meeting.
Okay.
It's about setting up our meeting.
Okay.
Looks like we're live on Facebook. Is that true?
I'm not seeing it. Are you seeing it?
It says we're live on the Zoom screen.
Oh, yes. Yep. We are good. We're going. All right. Yeah, Dr. Paulos, we are live on Facebook, so we're about 1 minute early. We can get started right on time at about 1.
Great. I'll wait for your thumbs up. Great.
Yeah. We're good to go. Let's start.
Good evening, folks. Ben Paulos here in Columbus, Ohio at Ohio State, a hernia surgeon, general surgeon. I want to welcome everyone to Hernia Live, sponsored by the Abdominal Core Health Quality Collaborative. We're really excited to have you here. We have an incredible array of speakers and also patients as speakers, which is something really unique to really highlight Hernia Awareness Month. June is Hernia Awareness Month, and we hope to have a live and engaging discussion. Also provide some hernia education for patients, and also obtain a further understanding of especially the patient perspective and also the surgeon's perspective in really kind of this collaborative effort to help our patients. The Abdominal Core Health Quality Collaborative, who sponsors this event, is really an organization meant to bring people together who have an interest in hernia repair, and those who have been suffering from hernias, and also those who help fix hernias. And that includes surgeons, industry members, hospitals, and of course, patients. One of the real, I think, advantages and fun parts of being part of the QC or the ACH QC is the engagement of our patients, and several of whom are here as speakers, and we look forward to hearing from them. This is an event that we also ask you to consider donating to the ACH QC. We are a nonprofit, and again, we overall work to help patients with problems of hernias and also to help maintain abdominal core health. It's really my pleasure to introduce our two moderators, two world-renowned hernia surgeons. First, Dr. Sharon Tofai. She's a hernia specialist at the Beverly Hills Hernia Center in California, and also a professor at Cedars-Sinai Medical Center. And I'd also like to introduce Dr. Kayla Blake, also a hernia specialist at the University of Tennessee in Knoxville. So I'll turn it over to Drs. Tofai and Blake.
Welcome, everyone. This is the first Hernia Live event for the ACHQC, the Abdominal Core Health Quality Collaborative. I've been a member of this collaborative. It's been my honor to help support the database, and I'm very honored to be here with Kayla Blake, and we'll be co-hosting a very fun, information-packed event with surgeons and patients working together to talk about 4 really important topics.
Yes. Thank you, Dr. Paulos, and thank you, Dr. Tofai. Yes, I'm Dr. Kayla Blake. I'm a hernia specialist at University of Tennessee in Knoxville, Tennessee. And we're super excited to have this event. Like they said, this is the first ACHQC event. And like we said, this group is a bunch of hernia specialists that just want to improve the care that we give to patients. So we're here with some of our own patients, just talking about our experiences, and we follow the outcomes of all of our patients so that we can get better. And again, we're a nonprofit organization, and we are here to help raise awareness for hernias, educate. And if you are a patient and you are interested in getting involved and talking to this group of surgeons and surgeons across the country and helping us improve outcomes, we'd love for you to join our committees and Any donations to our nonprofit is definitely welcome. We need to help, with data collection and statisticians and everything. So everything that you can do to help us in our organization just helps us improve the care we give to you. So without further ado, thank you so much for joining, and I'll give it back to Dr. Tofi, who will start introducing the event, and let's kick it off. Feel free to write any questions in the chat, and we will have a discussion after every speaker. There's going to be 4 topics tonight. So we will go through the chat and have a live discussion. So looking forward to it.
Okay, thanks, Kayla. So for those of you here on Facebook Live, remember this is live event, which is intended for you all to listen to, but also participate in. So please ask any questions as we go, but we will start because we're full of information that we got to squeeze into a full hour. So our first topic is Hernia 101. What is it? How do you recognize it? How are these hernias fixed? Mesh versus no mesh? Let's discuss all the options. I'm going to hand it over to surgeon speaker, Dr. Nora Fullington. She is a hernia surgery specialist at the Boston Hernia in Boston, Massachusetts, followed by Jenny from Knoxville, Tennessee, who will be our patient speaker.
Hi, everybody. I'm Nora Fullington. As mentioned, I'm a surgeon at Boston Hernia, so I'm in the Massachusetts area. And our practice is really focused on taking care of patients with hernia. So it really is, something that we're pretty passionate about. And I think most people here have a significant interest in it. So we all share that together. So my job in the next 5 minutes is to explain what a hernia is, how to recognize it, what a patient experiences, and all your different options. So I'll try to keep it brief and get through most of those things, but there'll be an opportunity to ask some questions as well. So first of all, a hernia is a hole in the strength layer of the abdominal wall. So things that are meant to be kept inside are able to bulge out. So what a patient experiences is a lump in an area where they didn't used to have a lump. And sometimes there's pain associated with that as well. You can imagine if something is bulging into a confined space, it gets compressed, and that can cause some discomfort. So a lot of times that's what patients feel, a lump and some pain. If the hernia is really tiny, they might not notice the lump, they might notice the pain, but kind of the typical picture is a new lump in an area where you didn't used to have one. They typically occur when it comes to the abdominal wall along the midline, because that's where our strength layer is the thinnest. So we tend to get holes in that space. So really common to develop hernias at the belly button. The other location that it's really common is in the groin. And that's because we have natural spaces in our abdominal wall for other structures to pass through. And so things from inside can bulge alongside those structures and create lumps. So that's kind of what a hernia is and what a patient would experience if they had one. So the next question that patients often ask us is, when should you do something about it, or should you be worried about it? So if we went around on the street and pointed at every different person and said, show us your belly button, we would find a lot of belly button hernias, right? We don't do that, thankfully, but we would find a lot of umbilical hernias. And there are really small belly button hernias scattered all over the world that are not causing any problems, that haven't increased in size over time, that don't cause any symptoms. And it is totally safe to leave those little tiny hernias alone. But over time, if a hernia increases in size or it becomes problematic, causes discomfort, causes a person to limit what they do because of concerns about that hernia or because of symptoms, it is, at that point that we consider doing something about the hernia. And specifically, the really only thing we can do to treat a hernia is to repair it surgically. So once a patient becomes symptomatic or the hernia increases in size, now we start to think about, what do we do about it? Now, this will vary depending on the type of hernia, depending on its size, depending on several different factors that are particular to an individual. So, things like their patient's past medical history, past surgical history, whether they've had a hernia repaired in that area before, even medications that they're on can have an impact on how they heal. So for that reason, we have to consider all of those things, and patients should, in that when they feel that they're kind of, A, they have a hernia, and B, they want to potentially do something about it, the best thing to do would be to talk to a hernia specialist, because a hernia specialist can kind of tally up all that different information and figure out what's going to be best. So let's talk sort of in general about different ways to repair hernias. And most hernia surgeons would agree that if you have a hole in the abdominal wall, and you kind of look at it as if it's like a hole in a tire, the best way to patch that hole is to put a patch on the inside, because every time you strain, there's any pressure on your abdominal wall, that patch is going to be pushed into that spot where we want it to be. So that is sort of a mechanical advantage. So essentially, that means putting mesh on the inside of the hernia hole. That's true both in the abdominal wall and also down in the groin. And so when we talk about putting mesh in that position, there are several different options. There is a laparoscopic or a robotic approach, which uses small incisions in the abdominal wall to get to the inside of that hernia defect and place mesh there. And then there are other options like an open repair. Depending on the size of the hernia and a few different factors, that open repair can also be minimally invasive. So you can have significant advantages to a minimally invasive small open incision, because that can be done under a local anesthetic rather than, say, general anesthesia that is used with laparoscopic or robotic approaches. So that is kind of the gist of mesh in very general terms. There are many more specifics that go into it depending on the type of hernia, but that is sort of the basics. The next thing just to talk about is this very popular approach of a no mesh repair. So a no mesh repair is something that's done with stitches only. So that would be particularly good for patients who are very thin, who are healthy, oftentimes in women, people who have strong tissues in that area. So those type of repairs rely just on your own tissues and the strength of your own tissues to provide that strength over time. Those type of repairs can have a higher risk of recurrence if the defect is larger or the patient is very heavy. So it's really important to think about the patient factors when deciding which type of approach to do. So most important in all of this comes down to patient factors. So understanding what a patient needs comes down to their past medical history, their surgical history, all of those different things, and really talking with a specialist in that area. Excuse me. So I will turn it over to Jenny now.
All right, that
Hi.
was very balanced and fair discussion in a very short period of time. Jenny, you're up.
Hi, my name is Jennifer Parks Collins. I'm 50 years old and I'm from Knoxville, Tennessee. I'm a disabled Air Force veteran and I've had 31 major surgeries and operations, nearly 20 of those on my abdominal wall or abdominal cavity alone. From age 19 to 29, I had 4 lumpectomies, numerous needle core biopsies, and ultrasound guided procedures for my family history of breast cancer. And finally, at age 29, the military surgeons did a double mastectomy. The reconstruction that they did was a tram flap. And a lot of people know that term. It's a transverse rectus abdominal muscle flap. It was explained to me as being, it was going to utilize my own abdominal fat along with the underlying connective tissue for an arterial blood supply to reconstruct my chest. And in 2003, I underwent that. And this was like the beginning of my hernia journey. They used Kevlar mesh, the same type that they use in the bulletproof vest. It's derived of the same materials. But 8 months later, when we were in Japan, again, stationed overseas, it popped loose. And from 2003 to 2009, I had 7 surgeries to replace mesh, remove MRSA, repair hernias with a patch here and a patch there. And finally, we moved to Germany. The language barriers were interesting, of course, having some Japanese surgeons there because they'd never seen the construction of, firstly, a chest, made of abdominal muscle and fat, and then my abdominal cavity as it was with all of this different materials and things in it. So when we moved to Germany in 2009, two of the hernia specialists from a Frankfurt hospital came to our air base and did 4 different surgeries, removing some corroded mesh, putting new mesh in. This was all plastic mesh up until that point. And then in 2015, here in Knoxville, to save my life from a bowel perforation, a surgeon cut me from breastbone to pubic bone, 26 inches vertically. And after weeks in the hospital, days on life support in the ICU, going back and forth to the OR for washout and bowel resectioning, I was left with pretty much no functional torso or core. From 2016 until 2019, I underwent, I believe it was another 7 surgeries here in Tennessee. After going back and forth to Vanderbilt and trying to find anyone who would attempt it, lots of them, many surgeons understandably would say, no, not with a 20-foot pole, you know. It was just so many different patchworks from so many different surgeons around the world. And I was living in abdominal binders, the elastic and Velcro ones, and then shapewear in addition to corsets, which are not as fashionable as I wish they would have been, because 24 hours a day gets a little tiring with it. After months and months of physical therapy, cognitive and emotional trauma therapy, dozens of other appointments through the VA for open wound care, and years sweating and living in shapewear, I was finally put in touch with a name I kept hearing over and over again, and it was Kayla Blake. And it happens that she was here in Knoxville, and I met with her. And 11 months ago, she did a grueling 11. It wasn't grueling for me, it was just for everybody else in the room, but an 11-hour surgery to remove old mesh, scar tissue, wires, clips, you name it. You know, mesh had grown in and out of some of my organs. And instead of doing patch after patch after patch, she's like, you know what? We're just going to wrap you in it all the way around, I guess is a good way to say it. I had missed for the last 9 years, and this is the part where I cry, so I'm going to do my best to keep together. For the last 9 years, I missed births of grandchildren, birthday parties, holidays, you name it. Just 2 weeks ago, I got to spend a week in Colorado. I flew there with my service dog, carried my own baggage, lifted up my grandkids, swung them around, danced with them. I got to go to a water park with them. I couldn't get in water for like 8.5, 9 years because of constant open wounds, and too much pressure on the external of my abdomen was excruciatingly painful. But because of her 11 months ago, and, you know, other factors too, my own health-wise factors, but because of Dr. Blake, I'm able to say, you know, hey, yeah, I can pick you up and swing you and throw you around. And yeah, I'm still Wonder Woman. My cosplay finally fits me again. So praise God and Kayla Blake. Thanks.
That's a great story. Jenny, you are Wonder Woman. So
Yeah.
I appreciate the little asterisk below your name. Kayla, there are a lot of questions coming in through Facebook Live, some of them related to Jenny's story. Can you maybe see?
Absolutely. Yes. Thank you, Jenny, for your story. And yeah, that was a tough surgery, but you're doing great. You are Wonder Woman.
Yes, ma'am.
And thanks for all that you do, for sure. So yes, let's get to the questions. Thank you guys so much for participating. So our first question is, do I always have to have a hernia fixed? Dr. Nora Fullington, what do you think? Do hernias
Yeah.
always need to be fixed?
Right. That's a great question. So I think the answer to that is no, right? So sometimes, like I said, if you have a small hernia and it's not bothering you, it's reasonable to not do anything about it. And I think that to take your question that one step further is, but will it at some point bother me, right? Will it at some point be something that has to be fixed? And not always. So people do live with tiny little asymptomatic hernias. It does make sense to do something about it as it gets bigger, however. So like Jenny was talking about, you don't want to get into a situation where this becomes a much bigger thing that involves a much bigger surgery and much more involved recovery and potential for complications and potential for need for further surgery. So no, it doesn't always have to be fixed. No, when you find a hernia, you don't immediately have to do something about it, but you should pay attention to it. If it becomes larger or if it becomes symptomatic, you should do something about it, because that is just an indication of what is to come in the future. Hernias do tend to get larger, and they do tend to become more symptomatic and problematic with time. So hopefully that answered your question.
That's a great answer, because a lot of patients are kind of pushed into, you have to have this surgery done ASAP. And then they may have complications, and then there's this regret factor. So it's very important to have that very honest discussion that we don't have enough data to know exactly who absolutely needs surgery and who will never need surgery. But we do know that there's a good fraction of people that may never need surgery because their symptoms are nil or
Yeah. And I do
they're low
think,
risk.
one way to take it is to go meet with a hernia specialist and talk about it. I mean, I always say to patients, like, we know each other now, right? Like, the decision is no today, but the decision might be not no tomorrow or a year from now. So it's okay to go have that conversation. Now, to your point, Sharon, I do think just be wary of the situation where it's all, yes, all surgery is always the answer, right? Like, that's not right either, but meeting with somebody who's thoughtful about it, who sees a lot of patients with hernias, I think can really guide you in the right direction.
Okay, there's a lot of more questions. Let's do the next section, which is our number 2 of 4 talks, and we'll start interspersing the other live questions so that we can get through all of these. Does that sound cool? All right. All right, topic number 2, setting up for success. What can you do to improve your outcomes? So the question here is, how do you best prepare for surgery to give yourself the best outcomes? And we'll go through all of that, and the ACHQC is really one of the major ways in which we can assess outcomes, and that's why many of us are members of it. Our surgeon speaker is Dr. Courtney Collins. She's a general surgeon and hernia specialist at the Ohio State University in Columbus, Ohio, and our patient speaker will be David from Chattanooga, Tennessee. Dr. Collins.
Hi, everybody. I'm Courtney. I'm from the Ohio State. You really have to emphasize the Sharon, or it doesn't count. Yeah, I'm going to be talking a little bit about how you can best get ready for surgery. And, I think that, one of the things I tell my residents is that there's no problem so bad that the wrong surgery or surgery at the wrong time can't make worse immediately, So I think it's really important that when you go in for a hernia repair, that you and your surgeon are on the same page about, your condition, and, that you're the best you can possibly be, because as we sort of just heard from Wonder Woman there, ideally you just want one hernia repair and never have to do it again, and certainly not have to do it multiple times. So I think it's really important that you, as a unit, as a surgeon patient unit, sort of do the best you can in the time prior to surgery. So I'll kind of review things that, and I think that means different things to patients and surgeons. I'm going to sort of talk about how surgeons think about getting patients ready for surgery, and then a little bit about, kind of what patients can do. And then obviously David knows far more than me about how to prepare on the patient side. So the QC has done a lot of research into, what factors really matter when it comes to hernia outcomes. And certainly there's technical considerations that are well beyond the scope of this broadcast. But in terms of comorbidities that matter, we sort of hover around 3, and that's diabetes, smoking, and weight or body mass index. And so briefly why those matter. So diabetes, obviously, having uncontrolled diabetes is bad. No one needs to, we don't need to harp on that. But from our specific perspective, it increases the chance that you'll have a wound infection after surgery, which of course is terrible on its own. But also bacteria really love sugar, and they'll just spread everywhere. And they can actually eat through your suture and cause problems with your mesh. So we have a very specific fear of diabetes that is poorly controlled or high blood sugars around surgery. So we tend to keep a close eye on that. The other thing is smoking. And again, some people think that surgeons are scared of smoking because, smoking's bad and we're somehow judging you for being a smoker. And that's really not true. From a hernia perspective, again, it does increase your chance of having respiratory issues after surgery, which is problematic. But also coughing after a hernia repair is not fun, so we want to try and reduce that. But again, more from a healing perspective, smokers have been shown to have decreased wound healing and just, trouble with their hernia repair taking after surgery, and it can increase your chance of recurrence. And I think we had a really great example of sort of what can happen if your hernia comes back over and over again. So that's sort of why we as hernia surgeons would prefer that people not smoke or try and cut down at least before surgery. And then the last thing is, weight and BMI. And again, that's a very fraught subject, I think, with patients and their doctors. You can't see me from the waist down, but I'm a curvy girl. So many doctors have talked to me about, how much I weigh, and I really should weigh something more like 115 pounds or whatever. But I don't. But I think, again, why we emphasize that I tell my patients it's a physics thing, eventually we want to put in good, strong stitches and mesh and everything's going to heal on its own. But in the meantime, our sutures have to be able to hold on for your tissues to do that, and so at some point there's just laws of physics that are just difficult to overcome. So again, not a judgmental thing. I love a good curvy girl out there, but you gotta, as best we can, if we can get it down, it's helpful. And then, of course, you want to think about your overall health, and so getting all of your comorbidities, or whatever medical problems you have as tightly controlled as you can is just going to make you feel better after surgery, frankly. It's going to help you get around. And especially moving around prior to surgery, really getting those muscles strong so that you're ready to kind of mobilize post-op is super important. But I think the one thing I really want to emphasize about this is that this should, whether or not you're ready for surgery, it really shouldn't be a black and white thing. And I think that's something the QC has done a really good job of, is kind of showing that some of these rules that we made, like you absolutely can't smoke, you absolutely have to weigh this, you absolutely have to do that, can actually be really flexible. Because how I look the best before surgery may look different than how someone else looks their best. My BMI is never going to be 19. But I could probably get it down from where it is. And so figuring out a realistic goal for every patient and figuring out what their best really looks like, I think is really, really important. So how can you really prepare for that? I think it's to just be ready to have a conversation with the surgeon very, very specifically, just what do you think my risk profile is based on what you know about me? And if I were to change XYZ thing, how would that impact my surgical risk? Would it be a lot or a little? If I lose 10 pounds, does it matter a lot or a little? What if I lose 50? What if that means I put surgery off 6 months? And kind of figuring out what you think the best situation can be before you go into the operating room. And I think the other really important thing to kind of go in to set yourself up for success for surgery is to make your surgeon help you, be like, okay, you want me to stop smoking? Like, how should I do that? Like, where should I go? What resources do you have to help me? You want me to lose weight? Okay, great. I've wanted to lose weight my whole life. How am I supposed to do that? Like, how can you help me? And I think that's really kind of on us as surgeons to really help patients along on their journey, not just be like, oh, you smoke too much, sorry, and then send them out, somewhere else to potentially have some kind of hernia emergency. So I really kind of encourage surgeons and patients to really just, see it as a conversation, and figure out what a realistic goal is for you. And then more importantly, how you're going to sort of go on that journey, together. So that is my piece. I'm sure David has many smarter things to say than I do about this, but I look forward to his comments.
All right, David, you're up.
Well, I appreciate the opportunity to speak. And I started out with an emergency appendectomy in the middle of 2010 that resulted in a diagnosis of appendiceal cancer. The treatment for that was a right hemicolectomy that I underwent in December of 2010. And that was successful. Went in for several years with no problems, and then developed an incisional hernia in 2019 that was not a discrete event, but a gradual bulge just underneath my sternum, and resulted in in the strangulation and rupture of my transverse colon in February of 2020. I underwent 4 emergency surgeries in the space of a week, including an ileostomy installation. And later in that year, underwent a reversal of the ileostomy and a sandwich hernia repair of the original hernia that was a synthetic and an organic mesh. About 6 months after that surgery, I developed a second ventral hernia at the ileostomy site and adjacent to it, and spent 2 rather frustrating years trying to get that resolved. I was finally referred to Dr. Blake in July of 2023, and she performed a complete abdominal wall reconstruction on December 15th, 2023. As far as pre-op preparations, along with spirometer for respiratory and walking, and some of my own diet attempts, Dr. Blake referred me to physical therapy and also referred me to their nutritional center in her practice. I went through an 8-week regimen with the physical therapist, and initially we didn't have the ACHQC app with us, but after we came up with a program, physical therapist, myself, and it was about 80% congruent with the exercises and the routines that's recommended in the app. So I felt very good about that. We worked on core strength, but we wanted to avoid the muscle groups that were adjacent to the hernia site for fear of further damage. And we also worked on arm and leg strength. And like I said, I walked, and the diet and nutrition, I needed to lose some weight, and the nutritionist there put me on a regimen, high protein, low carb, low fat diet that ran about 800 to 1,000 calories for 2 weeks. And then I went to about 12 to 1,400 calories for a couple of weeks. And I think the number is just over 50 pounds that I lost from July until December. And as far as post-op and recovery, I spent my surgery was about 7 hours. I woke up. My understanding is that I woke up from anesthetic very quickly and was back in the room. It was characterized by very, very little pain. I used oxycodone a bit as a preventative measure, but we got off of that quickly, and Tylenol did the job. We did some post-op physical therapy, and I've continued with the weight loss because Dr. Blake said the single best thing that I could do to prevent reoccurrence was to continue to lose weight. So I exhibited little or no soreness from the post-op, and that was the thing that I expected the most, but it just flat didn't happen. And that's my story. We're doing good.
Amazing story. That's an amazing amount of weight to lose on your own in such a short period of time.
Thank you.
That's awesome, David. Thank you so much. I'm glad you're doing great. You're a rock star. I would love to get to some more questions in the Facebook. So Dr. Topai, I have a question for you. We have a patient who's had a deep flap. And for those who don't know, that's a flap of using some of the abdominal fat and skin to help reconstruct after breast surgery. Sometimes a little bit of muscle might be taken too. There's also tram flaps that take a lot of muscle. And so there's a patient who has some bulging after a deep flap. Is that something to be worried about? Is that a hernia? Is that not a hernia? What would you recommend?
We're seeing more of these. Jenny talked about her tram flap, which is a little bit older generation reconstruction for breast cancer typically. The newer generation is using the deep flap, DIEP, it's an acronym. It's supposed to be less of an issue for the abdominal wall because the actual muscle is not removed. But in doing so, they have to go through the muscle and do two things. One is cut through the muscle so you can get a hernia potentially from that portion of the operation, where they have to harvest the blood vessels for the flap portion to keep the flap healthy. And then in the vessels that they need to cut out as part of the deep flap to transfer the abdominal wall skin and fat up to the breast. there are nerves right next to it. So you may accidentally, as a surgeon, injure those nerves. So what we're seeing, and I'm seeing unfortunately a lot of, because it's a very difficult problem to treat, is this asymmetric bulge, usually on one side, uncommonly on both sides, where the nerve is injured during the deep flap harvesting. There's no good way to treat it. It is technically not a hernia, but a lot of these flaps are done in young, healthy women, and now they're deformed from it because of the bulging that they get. And so there are procedures to help with that, because if you don't address it, you start getting more and more bulging, more asymmetry, and then a very difficult and painful heaviness in the area. So I treat it almost like a tummy tuck. You have to take that very kind of thinning out unhealthy muscle and tighten it to try and bring you as symmetric as possible with the other side. But that's not enough. You have to use a permanent synthetic mesh to hold that in place, because the sutures will not be enough for this unhealthy muscle area, because the nerve to it is no longer there and they get their nutrition from the nerve. It's a complex operation, and the results are not perfect. You know, it's very hard to get you symmetric like your normal side. But I have patients not only with one side, but I have had a couple patients where the nerves were injured on both sides. So now they have a very abnormal looking abdominal wall. But you have to see a specialist for that. That's not something that a typical surgeon would be able to address.
Great answer. Thank you. Thank you so much for explaining on that. Jenny, what do you think about it all?
So I wanted to chime in a little bit on when we were talking about the pre-therapy that you need to do before you have any kind of a surgery like this. For those who are not friendly of hospitals, you know, you've got anywhere from a 5 to 7 week stay. You know, that kind of thing. But more so than that, I did smoking cessation. I quit drinking alcohol once I realized alcohol turns to sugars. Sugar's not good for healing, you know, and the funny thing is, from 2003 up until I quit drinking and smoking in 2011 and 2013, those surgeries, they were reoccurring. It just kept reopening. I kept having wound care. And when I realized it's detrimental, that's when I started to be able to start healing, you know, properly from it. It was eye-opening to me when one of the doctors said 10 pounds is about 8 points on your blood pressure. And blood pressure is so important, especially after I had my tram flap. I had blood pressure cuffs on my arteries in my chest. So, you know, being a smoker at the time, I remember I thought it was crazy that they were like, here, take your IV, pull outside and have a cigarette back then. And I said, okay, you know, but it's a huge difference when you're trying to heal from a surgery after being a smoker and a drinker to, you know, being much cleaner, dropping the weight. Like David was saying, you know, you've got to get yourself precognitive therapy. You've got to be ready for the best possible outcome, you know, hope for the best, but expect anything that could go wrong. I learned that after like surgery number 8, that sometimes it's just not going to work.
Thanks for sharing that, Jenny. Yeah, you and David are both great examples of how changing the risk factors for bad outcomes can get you to a point where you get good outcomes with, obviously with, you know, good surgeons there as well to give you the right operation. All right, let's learn a bit more about that on topic number 3. What do you need to know after surgery? What do you need to know about heavy lifting? Are binders helpful? What's the best pain control, and how do you navigate complications? So let's have our surgeon speaker start, Dr. Ariel Perez. She's a general and trauma surgeon, hernia specialist from the University of North Carolina in Chapel Hill, North Carolina. And our patient speaker will be John from Northport, Florida.
Hey everyone, my name is Ariel Perez. Thanks for the introduction, Dr. Tofai. So just to kind of get straight off the bat here and really think of, from a patient perspective, what to expect after surgery. You know, we've kind of heard about it from our patients and from our other speakers. really the big thing after hernia surgery is you want to let yourself heal. You want to let those muscles actually get back together again, heal back together. You want to make sure that that mesh that gets placed is actually getting integrated into those muscles so that you're going to have the best repair and the least likelihood of having that hernia recur. And so one of the things that I'll often have my patients do is, if they have a smartphone, whether it's an Android or an iPhone, I have them go and download that ACHQC app that David had talked about. I think it's a really great thing. It gives you a lot of information about different stretches and exercises and different ways to prepare for the surgery, but also what to expect after surgery. Exactly how much to lift. Really, after surgery, you want to limit how much you're lifting. It's mainly because, from the perspective, kind of the physics, you want to try and avoid as much pressure on the abdominal wall so that the muscles aren't really pulling apart, that they're really able to kind of stick together and heal as best as possible. And I'll often tell my patients, for the first 2 weeks, don't expect to lift anything or try to not lift anything heavier than about 5 to 10 pounds, and that'll reduce the amount of strain on the repair. It does take a few weeks to a few months for the tissues to fully heal after surgery. So really kind of listening to the body in terms of how much kind of pressure and how much strain you're putting on the body. In terms of trying to help out with pain as well as to reduce a lot of that pressure and a lot of that strain on the abdominal wall. Oftentimes I'll have patients wear some sort of abdominal binder or a compression garment. And that provides not only kind of compression to the abdomen to kind of help keep things in so that if you're coughing, if you're sneezing, it kind of helps to provide that backwards pressure. It also just provides almost a compression where I've had patients tell me that they notice actually a difference in terms of their pain control when they have their binder on or off. It provides a little bit more security. So that abdominal binder is really helpful. Oftentimes after a big kind of hernia repair, initially, really to help out with that healing, I'll tell my patients to try and wear that night and day. Take it off in the shower, but wear it night and day for the first 2 weeks, and then afterwards, after that, you can just wear it, especially during the daytime, especially when you're doing some heavy exercises. And as far as pain control, you really want to be able to control your pain so that you're up and walking as soon as possible. That's going to get the blood flowing. That's going to help really reduce any sort of blood clots or any other issues that can develop. You want to be able to get the blood flowing and be able to move quickly right after surgery. And so you want to have that pain under control. It might need some narcotics, but hopefully it works well with just some adjuncts and you're able to avoid narcotic pain medication. But again, I can't kind of say enough good things. I found that the ACHQC app is very beneficial, and it gives kind of these 2-week increments for patients to know what to do right after surgery. And if there isn't a smartphone, they can always go onto the website and they can actually just download the printout for it. And so sometimes I'll just print it out for patients in the office to be able to have available and to bring it to a physical therapist after recovery. In terms of pain control, the ACHQC has done a lot of work. Starting in 2019, Dr. Mickey Reinhorn kind of started this opioid reduction task force to look at, are our patients really getting good pain control, and are we properly kind of addressing their pain with the right medications? We see a lot of news coming out about opioid addiction and opioid abuse. And what we've kind of been finding, especially with being able to track our patient outcomes through the ACHQC, is we're finding that most patients actually, by the time that they have their surgery and they leave the hospital from discharge, they're not actually needing opioids if they're able to get the right adjuncts. Oftentimes, if we're thinking like a groin hernia repair, using some local numbing medication that gets injected at the time of surgery by the surgeon, and then kind of taking care of that, icing the area, Tylenol, ibuprofen, muscle relaxants can all help to reduce the need for opioid use after surgery. And then in terms of how patients should navigate post-operative issues. So, whenever there's any concern that something might be going wrong with the recovery from surgery. I think the best thing for a patient is really to contact the surgeon right away. That way the surgeon can come and have you come in. If there's any concerns, it might mean that the surgeon needs to do a physical exam. You might need some imaging to just double check and make sure that everything's okay. And if you're still concerned and there's you feel like something's going on and you don't feel like something's being addressed, I don't think it hurts as a patient to go ahead and ask for a second opinion from a different surgeon as well. But definitely, I think being a great patient advocate, either for your friend or yourself, to make sure that everything's going right with your healing and that you feel reassured is very beneficial. And lastly, when to seek a hernia specialist. So, I think the definition of a hernia specialist isn't well defined. There are specialists that have been formally trained in hernia and abdominal wall reconstruction with specialized training. But then we also have wonderful general surgeons who have really made it their passion to focus on hernia and abdominal wall reconstruction. And so I think as patients, one way that you can find these hernia specialists are really kind of asking around, trying to find surgeons that are dedicated to hernias, to hernia repair and abdominal wall reconstruction. Do they track their outcomes? You can check on the ACHQC website if they're a verified quality surgeon and that they're dedicated to tracking their outcomes. Because I think from a surgeon aspect, you want to make sure that what you're doing is hopefully the right thing. And you're able to do the right thing for the patient. So, as a patient, I think finding that hernia specialist is going to be finding the right person or the right surgeon that is dedicated to really focusing on hernias and problems with the abdominal wall. You can ask the surgeon how many of the surgeries that they've done. And the other thing is with the surgeon, what type of options can they offer? Can they offer repairs in both a minimally invasive through small incisions as well as an open repair? Do they do things like muscle separations? Do they do mesh and no mesh repairs? Finding out exactly what the repertoire or what type of operations that surgeon can offer. And I think for any patient, if they're considering getting a hernia repair, just kind of asking the surgeon about what their experience and what their exposure is.
That's awesome, Dr. Perez. Thank you. I'd like to hear from John. What's been your experience in the recovery period?
Well, first of all, Dr. Perez, thank you. I agree with everything that you said, and I'm going to emphasize a few points. But my experience started when my dermatologist told me I had a lipoma on my belly button. And then about 9 years later, I woke up one morning, I had a lot of pain, and I knew it wasn't a skin problem. So I did some research. It was during COVID, so I didn't want to travel too much. So I found a highly rated surgeon and asked him a lot of questions, and basically had a umbilical cord surgery. It was only 1 centimeter. It was very small. And then basically the pain didn't go away. And then I found it was like having a python wrapped around me. So eventually I went to an HQC surgeon, and he recommended I wait first to see how but it got to the point where we both realized that I needed some intervention with it. So basically, he did a mesh removal surgery, and that's when I learned about the QC app. When I was in the hospital, he kept me overnight because mesh removal, it's messy. Okay, you're taking something out of your body, and I was quite sore, but they did want me to move around. But just like Dr. Perez said, that the QC app is really helpful. And one of the first things that it talks about was the binders. Actually, none of my surgeons had mentioned a binder, or if they had, I didn't remember it. But what I did have at home, we had this Mueller wrap that we got at Walmart, about 5 foot long. And I'm pretty skinny, so basically I wrapped it around there, and I found that I didn't need much pain meds when I had that wrapped around there. Kind of like when you sprain your ankle, you want to protect that area. And really, I'm a big fan of binders. Especially for abdominal area. I don't know about the other types of hernias, but for me, this is really, really a lifesaver. And then as far as the, after the operation, it's really important to write down something significant. Okay, let's say, like for me, I got a skin rash, right where the surgery was. That's strange. I wrote it down, I took pictures of it, took video of it, and then I talked to the doctor, the first surgeon, and when I went back to see him, actually, I said, I feel like Apollo 13. Houston, we've had a problem. And he said, my patients don't get pain. I said, well, I did. So, but anyhow, I think he was sincere. I think he had never seen a complication before. And I learned that by going to the next step, saying the word next, I just left his office, and then I started searching for a surgeon that could help me, which turned out to be my miracle. But because I kept my mind like focused on the future and not dwelling in the past, then I could easily make that transition. It was upsetting, of course. And I mean, he did the best he knew how. So I moved on, and I'm glad that I took those notes. I mean, because when I called the office, they wanted to give me antibiotics, which we weren't even sure there was an infection or not yet. So as it turned out, actually, when the mesh was removed, the mesh had formed adhesions to my small intestine. That's why when I breathed in, my abdomen just rotated like this. But after that, it took me like maybe 6 weeks to recover, but I did follow the instructions. You know, the post-op instructions are really helpful because they help you prevent, from getting any kind of infection. And also, you got to move. You got to move your body. So it's that's why I'm going to talk a lot about the binders, because they are great. And if I have to go through this again, I'm going to buy a brand new a binder, so I don't have to use these again. So
That's
that's
great.
my story.
I am so happy to have so many patients involved in this Hernia Live, because your stories are so real, and we can learn so much from them. So we have a lot of questions to get caught up from. Dr. Blake, you want to talk about our
Yes.
Facebook Live audience?
Yes, let's get caught up on some of these questions. Thank you so much. So we have some questions on selection of mesh and what patients should think about and do about with that. So Dr. Courtney Collins, you spoke about just how to get ready for surgery and what patients should be thinking about going into surgery. We have a good question on, is there a method to how we pick a mesh for a certain patient? Is there a method on where we put the mesh in the abdominal wall, and like how do we make that decision for each patient, because there are a lot of different types. And then I'm going to wrap a second question in there. What if there's lawsuits to mesh? How do you address that with your patients?
Wow, it's like that's like the loaded question of the night, right? Is all the mesh lawsuits. I will say, and I really believe this, that no surgeon is going to advocate for putting something inside your body that they don't trust. I think there's like this perception somehow that like for every mesh we put in, we get like some kind of kickback. And if that's true, I'm still waiting for mine. So like, that's really not how it works. With every patient, I think we try and pick what we think the best option is. And you've kind of heard that sometimes, and I think if you were to poll all of us with a certain patient scenario, we might have slightly different answers. So it's important that you find a surgeon whose answer makes sense to you, because I think, again, this is a relationship and a conversation. For me, I balance mesh selection. Really, my first thought is I don't want the hernia to come back, you know. And again, it's kind of going back to Jenny's story, right? Like you want the repair to be the repair if you can, you know. So I want to do the thing that I think is the least invasive, but also has the best chance of long-term success. So sometimes that means that I'll go for a heavier mesh for, you know, for example, in a bigger person or a bigger defect or something like that. And I feel it needs a little bit, you know, more weight to it. That does increase the infection risk, for example. So then you have to sort of balance that against comorbidities and, you know, if they have a history of infection and that sort of thing. So I try and look at every hernia and every patient as kind of a unique situation and really tailor it for their situation. And certainly, you know, the mesh, no mesh conversation is something that you should definitely have. If you are really uncomfortable getting a mesh repair, I think that's totally fine. I don't do a lot of non-mesh repairs, but I'm more than happy to send you to someone who does if that's something that you feel is right for you. And that's the right that you have as a patient, I think, is to find somebody who's really going to engage you in the conversation and find something that you think together will work. In terms, but and so it's going back to the lawsuit thing, you know, I think responsible Googling is fine. What I will say though, is when you Google these things, just, you know, make sure that you're looking up reputable sources and not, I don't even know, like is inquirer.com a thing? I don't know, but you know, you know, make sure you're actually reading, you know, reputable things. Bring it to the appointment if you're worried and talk about it with the surgeon and kind of go through it. Because I'm happy to engage patients who want to be sort of involved in their care, and I want them to have their questions answered and not go home wondering. So I think it's really important you bring all of that and say, I saw this specific thing, like this is what I'm worried about, so we can sort of go through it together.
Yeah, I think we often don't know what the worry and concern by patients may be because we don't know their experience. You know, just today, my patient was worried that he's going to have like urethral perforation from his Foley. That was his major concern from the whole hernia repair. I'm like, that doesn't usually happen. And so on. So it's just whatever their experience, what they knew someone who, or read about someone who had that. All right. Here's what we're going to do. We have one more talk, and then we will try and answer as many of your questions as possible. We may go a little bit beyond our 1 hour if that's what it takes, but bear with us. We're here for you. Number 4, communication barriers. How do I talk to my surgeon? Well, let's hear it from Dr. Brian Willis. He's a private practice general surgeon and hernia specialist at TriHealth Montgomery, Ohio. And then I think after that, we'll have our patients chime in and then help answer some more questions on Facebook Live. And Dr. Ellis, you're up next.
Thanks, Dr. Tofi. So I think for my part, you know, what can you do as a patient to be to advocate for yourself and to get a good experience is I think you really have to build a healthcare team, just like you're building a sports team. You want to find and surround yourself with people that you can trust, that you can communicate with, and that you feel like that you have a relationship with, and that you can be part of the decision-making process. So I think that's really the first key to do to have that, you know, together. And then once you get your team together, there's a couple things you can do as well. You know, when you prepare to go for your visit, make sure that you kind of write down a list of questions. If you go onto Google and you look, like Dr. Collins said, there's good stuff on Google, but there's also a lot of information that is outdated. It may be wrong. It may not be relevant to you. So write your questions down, bring them in, talk to your surgeon, make sure that you can have a communication and they all get answered. Also bring as much, like if you've had multiple surgeries, bring as much of that history with you as you can. So you and your surgeon can sit down together, go through all of that. You can kind of get a better plan of what you're going to do based off what you've had done in the past, so you don't do the same thing again or have, you know, a similar outcome. And then I think, you know, you want to ask your surgeon, like, what complications do you see? And then how do you handle those complications? So what could I expect if this happens or if that happens? Because a lot of the fear of like, I don't know what's going to happen can be alleviated if you kind of address that up front. And hopefully it won't, but if it does, at least it's not so anxiety provoking. And then if you don't get all your questions answered in your first visit, make a second visit, go back, sit down again, bring, you know, more information with you to try to get comfortable with that. And you should also ask your surgeon, you know, what can I do to maximize myself? So like we've talked about, weight loss, stop smoking, all of those things. I mean, you really want to make a plan with your surgeon before you enter into the operating room. And even with all that, there's still there can be barriers to communication. So the definition of that is basically a disconnect from that prevents a message from being received. And lots of different barriers that we can have. There's lack of clarity, there's information overload, there's cultural difference, language barriers, medical terminology, and then the PTSD of emotional and historical visits to the doctor that may prevent you from hearing what he's saying or she's saying in the same way. So a lot of times it's important to bring a friend, bring a family member, bring whatever that can kind of help you get through the conversation. Don't be afraid to ask for clarifications. Don't be afraid to ask for, like, I don't understand. This really doesn't make sense. And then a lot of times I do a lot of my discussions with pictures. So a lot of times internet images or pictures or drawing things out makes it a lot easier to understand. Pictures worth 1,000 words. So and if you feel like you're not being heard by your doctor, I think it's important to be honest. Like, I don't get it. This is not what I want to do, or I want whatever. So it's good to kind of review how you see it, kind of review your goals, what you want to get out of it. And then, it's like we said, it's always good to get a second opinion. That never hurts anything. And a lot of times if you hear the same thing a couple times over, you're doing the right thing. So you want to make sure you have enough information as you can. So with that, I'll turn it over to John and Dave and Jenny.
Perfect. Thank you so much, Dr. Ellis. That was awesome. That was really, really great. So we only have a few minutes left. We might go over by a couple minutes, but we're definitely going to get to all your questions. So there is an excellent question in the chat that I would like to direct to Dr. Perez at UNC in Chapel Hill. So question is, I had a Spigelian hernia repair that was extending to a flank hernia. And after that operation, this patient has had some numbness and some nerve pain with some burning type pain going down to their hip and their groin and their upper buttocks since surgery. It's starting to improve with time. So what do you recommend for that patient? What should they expect? Do you think that's going to keep improving? What are some explanations for those symptoms?
Yeah, so I think after surgery, there's going to be a lot of different sensations and a lot of different feelings that patients are getting right after surgery. I think the good thing that I'm hearing is that it's starting to improve and it's getting better. Anytime that we're having surgery and the surgeon is doing some dissection in that area, there's going to be some sensory nerves that can get very irritated or trapped in scar tissue. And just over time, it may get better, but sometimes it does end up developing into chronic pain and to a lot of discomfort. And so it can sometimes take a little bit of kind of time to figure out if this pain is going to be getting better or if it's going to or if it's going to be something that's staying there. Sometimes it might be that working with some physical therapists to do some strengthening and to do some stretching may help it out. Sometimes a short course of a neuropathic pain medication can help. Other times it may be double checking and making sure that there is not a hernia recurrence, or there's other musculoskeletal reasons for that pain. But I will say that postoperative pain is something that can that's to be expected, but it should continue to get better. But it's something that, if it's persistent, really should continue to be evaluated to ensure that it gets taken care of properly.
I would add to that specific to a Spigelian, especially if a flank type and a flank type hernia, the ilioinguinal and iliohypogastric nerves are at risk for injury during the time of either closure of the defect or placing of the mesh and suturing in the mesh. So if you're not better after a reasonable period of time, you may actually have a direct nerve injury, and it's more common in these kind of lateral hernias. And that would give you groin pain wrapping around to your back and then down into your groin and inner thigh.
Awesome. Thank you so much. Thanks for explaining. Dr. Perez, we have another question for you specifically after your talk. You talked a lot about some adjuncts after surgery in terms of pain control, not just opioids, but using some other, Tylenol, NSAIDs, stuff like that. A patient just wanted to know, have you had any issues with the other adjuncts? Are there any risks of adding these on to a normal opioid? What's your risk benefit algorithm when you think about opioids versus using other types of pain control? What do you think is better long term? What does a better job at treating pain? What works the best in terms of treating pain at every type of level?
Yeah. So, no medication is without its potential risks. But oftentimes, what I'll initially start with when I think about adjuncts is thinking about using some sort of ice pack to help with some swelling, to reduce some discomfort. As a patient, you want to make sure that you're not leaving that on too long, that you're not putting that directly on your skin, because you can cause almost this freezer burn to the skin. So that's something that patients may want to watch out for with using ice packs. So oftentimes I'll say 10 minutes on, 10 minutes off. Make sure that you use a washcloth in between the ice pack and your skin. With the Tylenol, you want to make sure that you don't have a history of liver disease, because Tylenol is not a benign medication. There are possible consequences of liver injury. So you want to make sure that you're taking the appropriate dosage of Tylenol if you can take it. And then similarly, ibuprofen or other NSAIDs can cause kidney injury. And so if you have a history of kidney disease, you may want to talk with your doctor about that. If you have a history of ulcers, or other operations that you may have had, like a gastric bypass, NSAIDs may be something that you want to avoid. But that all being said, oftentimes what we see are these other adjuncts like ice, Tylenol, ibuprofen. They tend to have a little bit less of a habit forming issue than opioids, as well as there's not that similar kind of black market where you kind of get these downstream effects of having kind of these loose opioids that can be in a household.
Awesome. Thank you so much. And there's a follow-up patient who's asking a question about if they have chronic pain, is it normal for the surgeon to be managing their pain, or is it more normal for them to see a pain specialist around the time of surgery?
So I think it's very helpful to kind of be seeing the hernia first, your surgeon, to try and evaluate to make sure that there are no other post-operative issues. But in terms of chronic pain after surgery, it really helps to be able to see a hernia specialist who's able to evaluate, just as kind of Dr. Tofai kind of elaborated, are there specific nerves related to the surgery that could be causing the issue? And at that point in time, oftentimes the hernia specialist may consider other kind of methods of taking care of that chronic pain, whether it be nerve injections or neurectomies. But yes, in terms of the chronic pain, it's going to be kind of this team effort, both the surgeon as well as a chronic pain specialist.
Awesome. Thank you so much. And
Danny, you have your hand up. Did you want to add to that?
Yeah, I wanted to let you all know, do not understate the power of that precognitive therapy that we were talking about before surgery, because as long as you go into it, and like I said, you have to expect the best, hope for the best, but expect that something might not be the best. As far as pain control, I've run the gamut from zero pain control, Tylenol, opioids overseas, everything in between. And for me, one of the best things that I found is because the pharmaceuticals, just about any pharmaceutical pain medication, especially the narcotic ones, they'll tend to kind of upset what we just fixed in our abdomen. We don't want to have to be pushing when there's things being rearranged. And rather than taking laxatives, one of the things I've always said during my surgeries is prune juice. Just natural prune juice, get that on board, because the laxatives are so harsh on your system after just having all of this surgery. I just wanted to throw that out there.
That's excellent. Excellent point, Jenny. Thank you so much. So we have one more question, and that'll be the last question of the night. And the question is for Dr. Ellis. You spoke about communicating with your surgeon. How should patients ask questions? There's a great question about would asking the surgeon why he or she is selecting that mesh, is that appropriate? And how what are the factors related to the patient in terms of selection? So I guess, how should a patient ask their surgeon why they're using that mesh or why they're doing what they're doing? If you were the patient, what would you recommend?
Yeah, I would definitely think that's a good question to ask and try to understand what the mechanics of that specific type of mesh has and why is it applicable to them. So I think it's good to understand, their pieces of artificial material and how they get incorporated, where you're going to put them, how they're going to act, what's the expected, way it's going to prevent the hernia from coming back or improve the outcome. So I think those are all things that, as much as you want to go into detail of how much that can help you down the road and how that's going to be affected. And then also ask, what are the side effects of, all mesh have side effects, all mesh have benefits. So what are the expected side effects or what are potential side effects or complications that could happen? So you know what to look for down the road if it would ever be a problem.
Thank you so much. Well, we are going to wrap it up. So I just want to thank all the surgeon speakers and all the patient speakers. You guys were awesome. And I want to specifically thank all of our viewers and our listeners. And we are here for you. We want to hear from you so that we can all do better for you. So this is what the ACHQC is all about. We're about collaboration with our patients, collecting real-time data, getting feedback ongoing before your surgery, after surgery. And so as much as you guys want to be involved with this organization, we would love for you to be involved. Again, there's a lot of committees. We have a lot of resources on our apps that we have made for our patients that has physical therapy, pain control, pre-op stuff, post-op stuff. It's excellent. So if you are interested, our website is achqc.org. If you want to donate to the cause and help us grow this collaboration with patients and surgeons around the country, any help and generous donations is definitely welcome. Again, we're a nonprofit and we are just here to do our best. So thank you again. That'll be it for tonight. And we would love to hear from you soon. Have a good night, everybody. Thank you.
Thanks, everyone.
Thank you. Great job.
Great job. Thanks for having me.
That was awesome, guys. Good job, everybody. Super inspiring. Thank you all. That was so good. I didn't speak once. Great job.
Awesome. We are.
Thanks again for
Thank
having me.
you.
That was great.
Absolutely. Looks like we are still live, so we are going to go ahead and end this. Thank you all. Appreciate it.
Bye, everyone.
Bye, everyone. Thank you.
Thank you, everybody.
Thank you.